picture on the screen there is me, true to my personality.
Kristen, for my slides, are you going to give me control to advance, or do you want to advance?
I'm happy to advance it for you if that's okay.
Sure.
Is that okay?
Yeah.
All right. Just a few seconds here and we'll get going. All right, in the interest of time and because we only have 1 short hour for this webinar, we're going to go ahead and get started. For those of you I don't know, my name is Kristen Anthony, and I am the president and founder of the PTEN Foundation. I'm also a PTEN patient. I have a child with PTEN, and my mother had a PTEN mutation as well. So on today's webinar, you're going to hear a little bit from me, and I would like to introduce, and she will speak in just a moment, but Dr. Tua Powell. She is the Vanderbilt Medical Center Associate Director of Cancer Health Disparities and Ingram Professor of Cancer Research. She is also a professor of medicine and professor of pediatrics, and a fantastic champion for the hereditary cancer community. So I know you all will enjoy hearing from her. And if you have questions, a little bit of housekeeping, please put those in the chat. There will be time for Q&A at the end, and we'll try to get to all of your questions. And I just appreciate you guys for attending this webinar. For anyone who knows me, I am a very happy, smiley person. I have a lot of joy. And I think that's been super helpful in helping me navigate this scary diagnosis of PTEN hemeratoma tumor syndrome. That's not to say that I don't have down days and that I don't get sad from time to time. I do, but I always try to look for the bright side. So I thought that picture was appropriate, and finding joy on the journey after this diagnosis. Let's see, move forward. When the journey isn't one that you chose for yourself, how do you navigate that? I have a little video here, and at the end, if we have time, I will share that, but I want a lot of this webinar to be around discussion. So I will just keep going. When you are diagnosed with PTEN, there is fear, anxiety, sadness, worry, whether you're a parent or a patient yourself. You hear cancer, you hear multiple cancers, autism in some cases. Some of you have children who are nonverbal, so they can't verbalize to you how they're feeling, or if there's a concern that they have. It is super scary. And I would just urge everyone to grant yourself grace to go through all of the normal emotions with a scary diagnosis. You will have sadness, you will have fear, you will have anger, all of the things. But at a point in time, you will come to feel empowered that with this information, and some of us now with more and more awareness and more education are finding this diagnosis earlier. It empowers us to be advocates for our health, and even to advocate for new research, new treatment options. It's just a way that we can take over something that's negative and turn it to something that is positive. When you learn about this diagnosis, I always tell everybody to research and understand your options. to seek out the best physicians, whether it be one of our clinical centers of excellence, and I'll get to that in the next bullet point, or a large clinical center that is equipped with multidisciplinary care. And what that means is specialists in the different areas, cancer, gastroenterology, gynecology, neurology, all of the things. Large centers are equipped to best care for our patients. That doesn't mean that you can't go to one of these centers or come armed to your family doctor's visit with current NCCN, National Comprehensive Cancer Network guidelines, and share those with your doctor, because more than likely you will have greater information sometimes than the person sitting on the other side. All of these different resources, whether it's NCCN, NCI, NIH, these are all options for places you can go. I put a hyperlink there to our website. And if you're not able to capture that right now, you can call me. I'll make sure too to put my phone number in the chat, and I will show you, guide you how to get these guidelines. They are updated. They are medical board approved. I would suggest that everyone go to their clinical visits armed with this information. As I said before, look for centers of excellence. We are growing in that program. I'm very happy about that. We have Children's Philadelphia, Cleveland Clinic, and Boston Children's, and we've had several more reach out to us that are working to become a clinical center of excellence. No two PTEN patients are alike. And the reason I feel like it's important to emphasize that is there has been new research recently published that show us that in some cases, the cancer risks might even be a little bit higher than previously anticipated. Just what I said, no two PTEN patients are alike. So I don't want you to look at that information and have fear and anxiety over that. Just follow your clinical visits, stay with your family physician, with your care provider at a clinical center of excellence, and let them be your guide, and you will be okay. Many of the cancers that we are faced with are treatable, and very treatable if caught early. It's not always the case, but it's most often the case. So just remember that you're unique, and I don't want you comparing yourself to others. All right, this slide I like. Advocacy can be fun. The picture to the far left is me, goodness, back when I started this foundation, I think it was in 2013. We were on Capitol Hill advocating for rare diseases. And it has been one of the most fantastic experiences I've ever been able to take part in. I've made new friends. I've learned from other rare disease advocates how to be the best advocate that I can, not only for my own health, but for you all as well. So you see the fun picture at the House of Representatives there. We're having a good time. And then the pictures to the right, the little gallery that I have there, is also a very happy memory. Myself and a team of cyclists, we rode, well, some of them rode from Maine to Mobile, Alabama. Our team rode from northern Alabama to southern Alabama. So basically a whole day ride, about 220 miles to raise awareness for a rare disease. You can't see our little jerseys in that picture, but we have our blue and green and PTEN on the front. And this was way back in 2013, 14. So very early on, we raised money, and it was a fantastic experience for PTEN. So be an advocate. If you have questions about where do I start, again, reach out to me, reach out to Andrea. We would be happy to guide you there. What's next with the diagnosis? First, your diagnosis doesn't define you. You define what you will do with the diagnosis. I know you guys hear from Dr. Ng quite often, knowledge is power. That is the truth. Having this information will prepare you for the future, and you will live a happy and full life. Again, work with your care team to ensure the guidelines are followed. Be a loud voice if you have to. If you feel like you are not getting the best care, change providers. If you need help finding a new provider, reach out to us. I believe, and I think pretty much anybody on this call would agree, best practice healthcare comes from a team approach. That team starts with you, your provider, everyone that you see to get the best healthcare. You are all part of the process. So just remember that you're part of the team. You will also find a balance that works for you. We start off with lots and lots of screening, sometimes maybe a little too much screening. In a few cases, maybe not enough. Find the balance that works for you. You and your provider over time, they will get to know you, and you guys might have a comfort level with, okay, we're not going to go annually, we're going to go every 2 years. Or maybe we need to go every 6 months. It's a balance for each individual. And again, while we're all very similar, no two of us are exactly alike. I want you all to be an advocate. Use all of the information that you have available to you today. All right, so sharing your diagnosis with your family. I had the pleasure of getting to work with Dr. Powell on a program that she started and has grown tremendously around the hereditary cancer environment. And one of the things that we always talked about is, okay, you're faced with this super scary cancer diagnosis and you're looking for support, but maybe you go to a parent or a spouse or whoever it is in your family network, and they say, nah, don't worry. You just worry too much. Do not let that get you down. This information is processed differently by everybody. I'll give you an example in my own family. I was faced with this diagnosis and having a lot of screening and scary results from some of the screening. And I talked to a family member and they told me, don't worry, like you're letting your doctors worry you. You need to stop. Maybe you shouldn't go to the doctor. Well, naturally, I felt very isolated and sad by those comments. And it took me a bit of time to try to understand where the person on the other end was coming from. Well, as months went by, a few months and a year, there was more information coming out, some surgical intervention that was required for myself. And this individual came full circle from telling me, it's going to be okay, stop being a worrywart, to, I am on your team. I support you. I support your doctors and the recommendations that they make for you. And we're working together as a team now. So just give it time. But with that, I would like to hand it over to Dr. Powell, who's going to talk more about her programs and maybe touch on this topic just a little. I'll go ahead and advance and you just tell me as you go.
Sounds good. So thank you so much, Kristen, for the invitation. And again, I just saw in the chat and I just put in some instructions. So for this National Comprehensive Cancer Network, or NCCN as we like to call it, guidelines, the specific guidelines are breast, ovarian, pancreatic, but anyone has access to those, just to clarify. So all you need is a free username, like just make yourself a free username and password, and then you have access to these guidelines. And I know this isn't the topic, but just to kind of clarify, we update these guidelines at least on an annual basis. So the latest version that was updated just got released 2 days ago. So you can see how this changes. I'm the vice chair of this guidelines panel, so I am intricately involved in this whole guideline process, but I'm just trying to think what changed with P10. And actually, we reduced the age of screening for breast cancer in P10. So before it was 35, and that went down to 30 on an annual basis. So again, these guidelines change. So if someone was 32, they weren't eligible up until 2 days ago when they are now eligible. So again, I couldn't agree more with what Kristen said. I think it's really important to be empowered and to continue to kind of like take charge of your own health, because again, everyone's not going to know that the NCCN guidelines just changed 2 days ago and that, you know, you're eligible for screening that you may not have been. So just bigger picture wise, I'll try and keep this short because it would be great to have, time for questions. And as Kristen already went through my credentials, but I'm a clinical geneticist. So I'm a physician specialized in genetics. So, I take a lot of joy in that. My, research area isn't specific to Cowden syndrome, but I have patients with Cowden syndrome. And it is something that I see regularly in my practice. So a lot of the principles I'm going to go over are very general, like they're general principles to, well, what should we be doing? Where can we improve care in individuals with inherited cancers in general, including those with Cowden syndrome? So when you think about like having a mutation in an inherited cancer gene, I think of it as like threefold. In the context of a cancer diagnosis, it could refine treatment, right? In terms of future risks, figuring out, okay, well, these are the things I need to be doing in order to stay healthy, whether it is additional screenings or surgeries. And then the third part is sharing information with family members. And again, Kristen already touched upon this, but just because somebody tells you to share information, and just because you understand it, it's not always easy to explain that information to family members and for family members to then know that this is important and these are the next steps. So I think this has been well recognized across, a lot of research that has been done. And even in my own practice, this is something that I regularly talk to patients about. And, it does resonate with patients where, and families come in all different relationship types, right? So you have families that are very close knit, you have families that live far apart and that may not be as close knit. So again, I think we need to recognize it. And what I can tell you is there is a lot of research in this area, but again, I think we have a long way to go still. Next slide. So this, again, I don't want to get into the details of this, but a few years ago, we started, I have an inherited cancer registry, which I'll go through later, but within our registry, we have thousands of individuals with inherited cancer predisposition. So we kind of tried to, we surveyed them to see, okay, well, what are the barriers and facilitators? What makes it easier? What makes it harder? What kind of resources do you want in order to help share with family members? And we came up with a bunch of resources. On top of that, we came up with lists of facilitators and barriers. But in my mind, yeah, we came up with these lists, but what are the next steps? Next slide. So we have a toolkit. This is available online, but some of the things that came out of our research, and again, this is not rocket science. This is, these were things that we figured out, but some of which we already kind of knew. So the family sharing letter, Kristen mentioned already. Well, we have a way of automatically generating a family sharing letter just by, putting in your mutation, your family member, whatever you want, and then you can download it as a PDF. We don't save these things. These are just toolkits for anyone to use to help with generating a family sharing letter. And we have a video that we created where, again, it was to explain, well, once someone tests positive, why is it important for other family members to get tested? So again, this was, I'll tell you, version 1 of our toolkit. But based on this, next slide, please, we got a larger grant. And this is what Kristen is involved with us. And we've been very thankful for our advisory panel, which Kristen is part of, to kind of help guide us with, well, how do we make this patient-centric? How do we, what are we missing? What are the different resources that people want? So, our advisory panel has been involved in every step of us creating, evolving from our version 1 of our toolkit, I guess is the way I would couch it. So our clinical trial really is in individuals who have an inherited cancer gene mutation or are gene positive. We're looking at strategies on like remote strategies. So really strategies that are through internet-based tools to improve cancer risk management, as well as help with family sharing, family communication, really. So what I would consider is family sharing and then empowering families to get tested. I'll just touch on the cancer risk management piece. We've partnered with My Gene Council, which is a company where, again, the way they are set up is they have an internet, like an online tool through which they update information. So, if something about the mutation changes, if something about the guidelines changes, they push out that information. So it's a way of being able to manage all of these screenings. The other thing I will say is, again, Kristen touched upon this, but with PTEN, there are a lot of screenings that we are advising you to do. And I think one of the things that people don't necessarily talk about is, even if you have great insurance, that doesn't mean that you don't have a lot of copays, a lot of out-of-pocket expenses. So again, that is another thing that is currently under study. I know Ellen Matloff, who is the founder of My Gene Council, has really recognized this as well, what we call financial toxicity, even in the context of having great insurance. So again, I think that is an area of research that we really need to be pursuing. And I think from an advocacy standpoint, that's also super duper important to kind of let our lawmakers know that, hey, we're trying to stay healthy, but you're not really helping us with all of these additional costs that are kind of mandatory. Okay, so going into the family communication intervention, and again, I'll fly through this really quickly. Next slide, please. So again, there were steps that we were able to identify as we were building our tool for family communication. So decide whether to share genetic test results, plan who, when, and how to share results, choose materials to help share the results, and then review, support resources and others' experiences. So that's kind of what we built. Next slide, please. So again, we have some worksheets for folks. I'm so sorry. We have some worksheets on here. Oops. Okay, I don't know how to turn this off, so I apologize for this. But reasons why people choose to share, just some worksheets that we thought might be helpful as you're thinking through who you're going to share with and how you're going to share the information. Next slide. And then coming up with materials, like we said already about the family sharing letter, but there's more to sharing than just a letter. So giving them resources, fact sheets, depending on, okay, well, you have Cowden syndrome. Well, what are the cancers for which you might be at risk for if you're positive? What can you do about it? So again, empowering individuals with information, not super dense text, but with, information in lay terms as much as we could create. Next slide. And then videos. We created a bunch of videos to kind of give different scenarios. And again, I can't begin to tell you how helpful it was to have an advisory panel that had been through a lot of these scenarios that we came up with, and they were able to directly tell us, hey, here are some of the barriers. And I know Kristen was very involved in this piece. So those are the kinds of videos that we created in order to have that as something people could relate to as they're thinking about sharing. Next slide. And then videos about others' experiences with sharing the test results. So you kind of get the gist of it. Like there were various different resources. So we are testing this in the context of a clinical trial now. Again, I don't think this is the last step. I think this is going to work for some people, but I think what we really need to be thinking about is people need different levels of support. So maybe this is kind of a baseline support, but then we need to be thinking layering on additional levels of support. So really striving towards health equity. So giving people what they need in order to be able to act. Next slide. So that brings me to how we were able to even get to the point we've been able to get to. I had created something called our Inherited Cancer Registry. And this was over 10 years ago. And really, the whole concept was that we wanted to partner with both providers as well as individuals with inherited cancer across the country and beyond to provide educational resources, seminars, etc., to be able to also grow our registry. So in partnership, having people participate in our registry, which then leads to our ability to conduct additional research studies. So again, when we applied for this grant, what I can tell you is we already had our preliminary data based on already surveying participants in our registry, but now we have rolled out the clinical trial among our registry participants, as well as additional individuals as well. So it's not just our registry participants, but it gave us a foundation to be able to conduct this type of study. Next slide, please. And these are just some of the resources. We have newsletters, we have a website, we're active on social media. And what I will say is, just like these guidelines just changed 2 days ago. So in our newsletter, we will always put in, here are like guidelines came out, and just the lowdown of here are some things that changed that you may want to know about. So it's hard to get information because I think we are all overloaded with information, and our newsletter is truly focused on, you know, information relevant to individuals with inherited cancer. Next slide, please. And this is just an example of our social media. And again, it's pretty diverse. We have different offerings. We have talks, we have open studies, stories, research updates, guideline updates, as well as newsletters. Next slide, please. So I'm going to hand it back to Kristen.
Thank you, Dr. Powell. And one thing that I'm noticing is so much research around all of the different genetic mutations lending toward cancer, many of them breast cancer. I want to see PTEN more so at the center of a lot of this research, because I believe this community is growing rapidly. And I believe there's a lot of people out there that are not yet diagnosed that need to get a diagnosis. So Andrea, myself, the foundation, and colleagues are working really, really hard to push the needle on research for PTEN. And we've come a long way. Currently, we are working with physicians and other advocates with support from PTEN Research, PTEN Italia, and the international PTEN community to expand upon the current NCCN guidelines and make them even more robust based on what our patient community needs. As it grows, we find more and more information that is really helping with this process. So look for that soon. Also, I want to point out, we have a patient registry that is your patient registry. This information is research approved. What does that mean? We have an institutional review board that determines if the questions we ask are appropriate, the methods we use to recruit patients are appropriate, and myself and other coordinators, which there are not many, there are 3 total, have to go through rigorous training to be able to hold this data. Another reason this registry program is super important for you all is it allows you to make your voice heard, to help advance research, to accelerate the advancement of research, and to make sure that research is outcomes based from the beginning. Make sure these trials are designed with your needs specifically in mind. If you have questions, if you're like, I don't understand registries, can you tell me more? Can you tell me how my data is going to be used and how it's going to advance research? Please call me again. I'm about to pop my phone number in the chat. I'm happy to have a discussion with you about this. Let me tell you where we've already come from the information that's in there, and we have over 700 participants. A little over half of all of those participants have completed all of the existing surveys in the registry program. We even now have surveys available in English, Spanish, and certainly Italian, as this was a partnership with our Italian PTEN counterparts. Dr. Powell mentioned earlier financial toxicity. And I know if you're a PTEN patient, you would agree with me, no matter how good your insurance is, it is costly. We have a number of MRIs, CAT scans, biopsies, interventional surgeries for cancer in some cases, developmental care for our children and this should start very young, as soon as you can get them into programs. And if you're not able to get them into programs, see us. That is something we need to help you do. It's very costly. So in our registry, we ask a lot of demographic questions. Some of you work 2 and 3 jobs to keep your families afloat, which makes getting to the physician very, very difficult. And what we saw in an internal study that we did, there was a direct correlation between your socioeconomic status, what you're having to do to keep your family moving forward, and your reported quality of life. This was directly related. So we took the de-identified data. We worked with a genetics master's graduate, and we have a beautiful paper that we're hoping to get published soon that shows the need for additional studies on this financial toxicity. So thank you for bringing that up, Dr. Powell. Let's see, what other information did I want to share with you? Oh, coming up, things that are coming up. If you haven't heard, we will be joining PTEN Italia in Italy in September, the end of September, for our 7th annual Scientific and Patient Symposium. So this will be the first patient-led international symposium in Europe. And you can sign up. There will be a translator for any of our Italian folks that speak. I will be speaking, and other clinicians in our space will be speaking. So we hope you can join us for that. And I'm very excited to share there are 2 new clinical trials in the works. When I say clinical trials, it's pre-development of clinical trial, but there should be more information coming out about this soon. A lot of amazing things happening in the community. I know sometimes you don't hear from us, but no, we are working behind the scenes for you. And also very excited. I always say, no mountain is too high to climb. The climb is daunting, but we're going to do this together. So I decided, much like Leukemia and Lymphoma Society and other groups, that we were going to do something great to help in our effort to keep PTEN on the map and put us at the top of the map even. So we're taking a team to Mount Kilimanjaro, and we are going to summit on Rare Disease Day 2024. So far, we have Americans and Canadians working together. So if we happen to have any Europeans on the call and you want to join us, come on, we would love to have you. We have room on our team. It's a very doable trek. I can tell you more about it, but we're working hard also to raise money for our cause, for PTEN. And I believe that is my last slide. So we'll open it up for questions. Let's see if I can. Let me see if I can stop the screen share here. Stop share. All right. So questions in the chat. Here we go. If you are a parent of a child with PHTSO, join our Facebook group, okay? Thank you, Dr. Powell. Okay, Ms. Hancock, we will get you the guidelines, and I think Andrea put our website in the chat there, so you can also access those. If you can't find it, if you go to the little search tool and type in guidelines or guidelines brochure, it should come up. Let's see. Here's a good question. Could I ask if it is important or at least good to know, are there any clinical prevention strategy implications on which exact mutation a patient has? I never got any information from my physicians. Should I ask? I will, Dr. Powell, did you answer that in the chat? Did you see
Yeah,
that?
I did. So, I mean, what we call this is genotype phenotype. So does a specific mutation lead to different spectrum of cancer risks, which then translate to different screening or prevention strategies? And the answer, to the best of my knowledge right now, is no. We treat all PTEN mutations essentially the same. I'm not saying that's the right thing to do. It's just we don't have robust data to be able to kind of parse out higher versus potentially lower risk. You know, we're just getting to that point now with BRCA. So I do think down the road, that would be our hope. And that's why it's really important for participating in various registries, because, you know, that's how we get refined risk information. It's through people participating in registries and collecting that data. That being said, there are programs out there now, and I would encourage you all to touch base with your genetics providers where we can refine the risks, you know, based on mutation status, meaning, you know, if you have a PTEN mutation, but in conjunction with additional risk factor information. And by risk factor information, I'm talking about, you know, different lifestyle factors, like taking alcohol into account, taking breast density into account, taking, you know, other hormonal risk factors into account to generate specific lifetime risk to age 80 for breast cancer. The program is called CanRisk, and it is something that I would do on my patients regularly when I see them, if it is a score. So again, it's good for individuals who have not had a breast cancer diagnosis or who have at-risk breast tissue, to kind of refine the risks. Like, and again, I don't know that the risks are going to change what you do about it, but there is a difference in how you think about it if you have, say, a 30% risk versus a 50% risk. So it just, all that to say, we're getting there. There's another type of test called a polygenic risk score. And what that is, we all have different genetic backgrounds upon which, inherited cancer gene mutations live. So we're getting to the point where we can actually measure the genetic background through this polygenic risk score to raise or lower the mutation risks. So I do expect that that's going to become available in the foreseeable future as another strategy to refine the risks. So I think we're going to get better, but we're not necessarily there yet.
Thank you, Dr. Powell. And I see a question in here. Do you have some information on if taking sirolimus helps to prevent getting cancer? The answer to that is no. Currently, we do not. There are ongoing clinical trials in this area, so I would urge, if you qualify, to definitely sign up for one of those clinical trials. There will be statements in the guidelines once they are refined and published about external factors that could be cancer causing for PTEN patients. I think Dr. Powell mentioned alcohol, these external things that if we stay away from that, or at least practice moderation, that would be helpful for us with our cancer risk. And there will be information around sirolimus and everolimus coming out in these guidelines as well.
Kristen, I'm just going to also preface it. I do think it's important for people to live their lives as well and just keep in mind the magnitude of risk. And I say this a lot to the patients I see with BRCA, where if you have a BRCA mutation, it almost trumps many of the other risk factors. So if you want to have 1 or 2 glasses of wine, it's really not going to make much of a difference. So I don't want anyone to leave here thinking, oh, well, just because it was included in the risk model, it really affects risk. It really doesn't. It's, yeah, in the extremes, it will affect risk. But that's for all of us, right? If I was to have a lot of alcohol consistently, that's going to affect my risk too. So that's where, again, I would take those things with a grain of salt. I mean, for a lot of these risk models, the hormonal risk factors matter, many of which aren't under our control, right? You don't know when you're going to start menstruating. That does affect cancer risk. But then there are other things like breast density. Knowing about that is helpful because that definitely impacts risks as well. So no one thing is going to put you over a certain threshold. I think the one thing that will put you over the threshold is if you have the mutation. So that almost is the most important risk factor. So again, and I know that people talk about in our clinic, oh, well, should I put my 18-year-old on the birth control pill? Well, not necessarily. I don't know how much of a difference that's going to make. Or, should I have children early so I can remove my ovaries? No, I mean, you need to be living your life. Yes, it's something that is a factor, but we never encourage people to have children before they're ready to have children. So again, I think we just need to keep this in perspective.
I couldn't agree more. Yes, for sure. Definitely live with joy, not in fear by any means. There is a question: can a PTEN patient sign up for the iCare Inherited Cancer Registry, even if you currently don't have cancer? I think the answer is absolutely yes. Is that correct, Dr. Powell?
It is absolutely yes. So it's not based on a cancer diagnosis at all. We have we probably have, I want to say, over 3,000 people with inherited cancer gene mutations. So, being in the registry, we push out information. I will say though, even if you don't want to participate in our registry, that information is available on our website, which is inheritedcancer.net. We also push out information for clinical trials that are either our own or that we become aware of from others. So it just kind of keeps you looped into what's happening in terms of research and clinical updates.
Absolutely. Here's another comment question. Our daughter was diagnosed at the end of May, and my husband and I are both negative. So she developed this in utero. Do you think people attend symposiums and join clinical trials who are already have health issues such as cancer? Or should we attend to gain knowledge? Absolutely. Attend to gain knowledge. We as a foundation do provide travel funding to attend some of our symposiums, and we have had Canadians join us. It is so beneficial to connect with other families, spend time with them. You really see that you're part of a larger community and that people are doing generally well. So as a parent of a newly diagnosed child, I think it would be incredibly beneficial. And I don't think it's preemptive. I think you would find it beneficial.
I 100% agree. And I'm just going to say, like, so I'm Canadian, so I know about the Canadian health system. So when we talk about financial toxicity, that is one of the benefits in Canada as well, right? Like, because if you are eligible for certain screening, you get it at no cost. So again, I think the Canadian lived experience is different. There are a lot of genetics professionals in Canada, depending on where you're at. I think there are a lot of opportunities to get to experts, regardless of province.
Absolutely. But I would say, having some of our folks in the United States who have seen a number of PTEN patients, they're also able to give additional information. So if you can make it to one of the symposiums that we offer, definitely come. But we do have great clinicians in Canada, for sure. And I know of a lot of patients who are getting their care, including our Canadian friends climbing Mount Kilimanjaro with us. Yes, the Italian symposium will be virtual. We will be posting it quite frequently on our social media and then on our website. I will email out also answers to some of these questions to everybody who is attending today. Let's see. So there's some good. We'll get you information, Jelena, about how to sign up for the Italian meeting. Do we have other questions? We have about 10 minutes left. We can finish early if we don't have any more questions. You have a fantastic resource on this line right now. So, what is the, Dr. Powell, can you give me the iCare registry link? I'm going to go ahead and put it back in the chat again.
Yeah, it's inheritedcancer.net.
Net. And then if you don't catch that, and this is a global registry that I think is beneficial for the hereditary cancer community. And if you saw in Dr. Powell's presentation, even though some of those resources are available online, I think it's super beneficial to participate so that those resources will grow. And again, I want to see more targeted information about PTEN out there. So I believe it would be beneficial that more of us participate in this program. Anemia. Kimberly, I am not a clinician, so I cannot answer this. I do know of PTEN patients that have this. Dr. Powell, are you able to answer that question about anemia?
Only that it's not an established finding in PTEN.
Got it. But again, participating in these different programs where you share your personal experience and your information will help us group the different features together so that we're able to get a better understanding of the natural history of our disease. And we've already learned a lot from that information.
And just taking a step back when we're thinking about, how we've learned about Cowden syndrome, it's because we already talked about this, because people participated and we were able to kind of characterize it. What that also means is that if it's something that is not super common, you need really big numbers in order to figure out that, hey, something is associated. So that's why I chose my words carefully. Yes, it's not established, but does that mean it's absolutely not associated? I don't know the answer to that right now, but that again speaks to why we need to learn more to figure this out.
Absolutely. And we are for sure. And Denise, I also see your comment. My anecdotal non-clinical answer would be yes. I do hear this quite frequently. But again, it's not an established feature as of yet.
I've heard this clinically in my patients. I have too, but Kristen is absolutely right. It's not established.
Anyone else? And you feel free to unmute if you wanted to ask another question. I'll give you just a second and then we'll wrap up if we don't hear any. Our doctor says, Kimberly made a good point in the chat. She said her doctor says not everything is wrapped up in this diagnosis, but it seems she has more health issues than average. Yes, unfortunately, we do see that.
But this also speaks to what Kristen highlighted before, trying to make your way, like, especially if you're in the US, to a center of excellence, because you want to go to healthcare providers that see this day in and day out. And if you see it more often, you're going to have a higher level of expertise in this area. So again, even if you can't make it out regularly, I think traveling, the symposiums, I think, are a great idea, because again, the knowledge sharing that happens in many of these symposiums and the guest speakers that are brought in oftentimes are the world experts in Cowden syndrome. So again, I do think if there is a way of getting to those, and some of those, Kristen, correct me if I'm wrong, but sometimes these are also available virtually. Is that right?
Yes, absolutely. We have live streamed events before. And we also have a YouTube channel where in this webinar today, will be put onto our YouTube channel. Sometimes we'll have a clinical center that has some technical difficulty and we're not able to get all of the talks over to have them presented. But for the most part, we do try to get everything online for sure. Let's see, there's a couple more and then we'll take
any hints on where the new centers will be. Kristen, that's all you.
I would say not on the East Coast, a little bit west. Actually, we have two centers. We have one in the Northwest, and then one in the Mid-South that is interested. And me personally, being very near Vanderbilt, I would love to see Vanderbilt as a clinical center of excellence too. They certainly have the resources to treat our patient community there. Just putting my plug in, I won't put you under pressure to answer that either.
I would love to see it too. I'm with you.
Right. Let's see. There's just a couple questions.
So I see someone from living
Ireland.
Struggle as living in Ireland. Doctors don't know a lot about this. Okay, so the only thing I would say, so Ireland is not, again, I don't know how the healthcare systems work, but the UK docs are just unbelievable. Like, I have a lot of collaborators in the UK. Mark Tishkowitz, Helen Hansen, Gareth Evans, like all these people are really, like, they're leaders in the field. So if you can get over to the UK, you'd be in great hands.
Yeah, and Ireland is close, and Dr. Pell is absolutely correct. And Denise, so on the team refining guidelines, more specific academic guidelines for PHTS, Dr. Tishkowitz is on that team, and then we have who is in the UK, and then we have other members of the European Union on that team as well. So while advocacy is just a little bit behind there, we're catching up for sure in the UK and Ireland. So thank you. So I think these are the last couple of questions. You're welcome. That we can.
So the other thing, so Texas, MD Anderson is fantastic. They have a great cancer genetics program. So I would, the other place in Texas that is fantastic is UT Southwestern. I know both of their genetic counseling services, and they really are phenomenal.
Absolutely. And they're certainly treating a number of our patients. So, and we're working with some of those centers there. More to come on that. Ava Maria, yes, there are clinicians in Germany, but let me get back to you on that, because I don't have a specific name, but I know that there are that are recommended from our one of our PTEN geneticists here in the United States. So I will make a note to get back to you on that. Dr. Powell, you don't know someone specific in Germany, do you?
I do actually. Her name is Rita Schlumer, I think, but she's retiring soon, but she's got some junior people that are going to be taking over. If I can find that information, Kristen, I can send it to you.
Okay, great.
She's a surgical oncologist with specific expertise in genetics.
Awesome. Well, very good. Well, let's go ahead and wrap up for today. Dr. Powell, thank you. This has been fantastic. And not only speaking for myself, but our entire community, we really appreciate you sharing about the work that you're doing. And thank you for that work and programs. So if you want to know more about eye care, definitely let us know. Also, I want to say a big thank you to the National Genetics Education Family Support Center at Expecting Health, Global Genes, and Rare Disease Diversity Coalition. We received a small grant, and we are working on a number of things to improve our communications to the community through our registry, through email and messaging, more webinars like this. So thank you to those institutions that are supporting PTEN and the rare disease community. And Dr. Powell just put some of the names of our folks in Europe, if you want to quick jot those down. And we will wrap up for today. Thank you all for taking time to join. We really appreciate it. If you need anything, feel free to give me a call anytime, day or night. I'm an empty nester, so I'm happy to answer and speak with you. And we appreciate you guys, and thank you. And thank you again, Dr. Powell.
Yeah, thanks for the opportunity. Bye.
Take care, everybody. Bye-bye.